Hi everyone. So today I will be doing a VOPP on speech deficits. Again, sorry I can't be there, but hopefully this VOPP turns out really well. So to start off with, I'll be talking a bit about the brain. So hopefully you're all familiar with the brain by now. I'm just gonna see if I can get a pointer going. And yep, we're in action. So in the brain, there are a couple of main areas that you should have come across by now that are associated with speech. So here's Broca's area. So Broca's area is located in the frontal lobe of the dominant hemisphere and is important in speech production. Whereas Wernicke's area is here located in the superior temporal gyrus in the dominant cerebral hemisphere, and it's important for word recognition. So the artery that supplies both of those regions is the middle cerebral artery. That's really important to note, because obviously if you have a stroke affecting that cerebral artery, then it's likely then that your patient might have a problem with their speech production or their speech comprehension. So I also wanted to just quickly make a note about the use of the term dominant hemisphere. So that's generally the left in most people, so 95% of right-handed, and then I think just over 60% of left-handed people. So I guess it's just a little bit of a reminder to note that the dominant hemisphere isn't really related to handedness, which seems to be something to start off with. I'm just going to talk a little bit about altered speech. So it's really important to understand these definitions. So we have dysarthria is the first one, and that's really a problem with articulation. So the content of what the person's saying is linguistically normal, and basically it's a neuromotor problem in speech execution. So that's something that you can get with an upper motor neuron lesion, or some patients with Parkinson's will also have dysarthria. The next one, which is sort of the more important one that I'm going to spend a little bit of time on in this talk, is dysphagia or aphasia. So there's a bit of confusion about the terms. I suppose in the traditional sense, dys would mean reduced, and whereas would be like complete absence. But both terms are used interchangeably in this context. And aphasia is really preferred because with dysphagia you can get that mixed up with dysphagia, which is difficulty swallowing. So in the context of aphasia, it's a higher center disorder in the use of symbols for language, and that's the classic definition, textbook definition of aphasia. And as I was saying before, a lesion to Wernicke's or Broca's area leads to aphasia. So the lesion has to be in the dominant hemisphere for you to get that. Lastly, dysphonia is an altered sound of voice. So commonly that happens in laryngeal disease and also recurrent laryngeal nerve palsy. So hopefully you all know the classic symptom or sign of recurrent laryngeal nerve palsy, and that is the bone cough. So dysphonia is something that you'll learn a bit more about in second year, but for now we're just going to focus on aphasia. So types of aphasia. So we have receptive and we have expressive as well. So in receptive aphasia, we're unable to understand words. So that's the biggest issue there. So the patients with damage to Wernicke's area, they speak in what's called fluid nonsense. So they'll be speaking kind of at a normal pace, with sort of normal intonation, etc., but they won't be saying words that make sense. Like their words will be disordered and the words won't really be related to what they're saying. And they're generally unaware of the problem. So they're unable to understand and then they're unable to respond. But they don't actually have a problem in producing the words. It's just that the words don't make sense. Whereas in expressive aphasia, the patient can't organize or assemble their speech, so that's usually a problem with Broca's area. So they have broken or disjointed speech, and that can manifest as a stutter. And this is really quite challenging for these patients because they're aware of the problem. So they can easily get frustrated or upset because they're unable to express themselves. I've got a couple of videos that I'd like to show for each of these. So I'm going to try and get them up now. So this is an example of Wernicke's aphasia or receptive aphasia that I'm going to show you now. So here we go.
Hi Byron, how are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him. With luck for him.
So it was pretty clear there that although the patient was speaking fluently, his sentences flowed, he didn't really hesitate when he was speaking, and you can see that none of the words that he's saying are actually making sense, and they're not really following a logical pattern. So that's very, very typical of Wernicke's aphasia. And so hopefully you can gain a bit of an appreciation as well for what I mean by fluent speech. So he's got fluent speech there. And so now we're going to have a look at expressive aphasia where you have completely non-fluent speech.
Okay. So what's your name?
Scott. Oh, no. Sarah Scott.
That's right. And how old are you?
I can't.
Try.
I can't.
Oh. You're 19. 19.
Yeah.
Yeah. And what happened to you?
Stroke.
So hopefully you can see there how different expressive aphasia is. So you might already have seen a video of Sarah Scott speaking, but basically what I want to draw your attention to is what appears to be a lot of pausing when she's speaking. That can sometimes manifest as a stutter in those patients. And also you can see that she clearly understands the questions that the interviewer is asking. She just can't get her response out. And so you can see that she's frustrated and upset by that. So that's also something that you'll notice in patients with expressive aphasia. So moving on to a couple of other types of aphasia. So we have nominal aphasia, and in that the patient can't name things. So they'll engage in what's called circumlocution, which is where they sort of talk around and they describe the thing that they're trying to name. So, for example, I saw a patient who had nominal aphasia, and the doctor asked them to name the stethoscope, but they were unable to actually name the stethoscope. All they could do was list the things that the stethoscope can do. So that's the sort of thing that you'd be expecting in nominal aphasia. And that occurs in the dominant posterior temporoparietal area. And And that area is also supplied by the MCA. So the patient that I saw actually had both expressive and nominal aphasia because they had quite a significant stroke affecting the middle cerebral artery area. The last type of aphasia is a little bit harder to understand and pick up, but conduction aphasia is what it is, and it's damage to the arcuate fasciculus, which is the connection between Wernicke's and Broca's area. So this is another type of fluent speech, but it's disorganized. So the patient actually can't repeat things, and that's sort of the classical finding in conduction aphasia, and that's sort of how you would distinguish it from receptive aphasia, because as I was saying, both of those are fluent aphasias, which I'll talk a little bit more about when I talk about speech examination. But the last point that's important in conduction aphasia is that comprehension is intact. So the patient does understand commands, and they understand what you're saying, and they sort of have like a fair idea of what they want to say. They just have a lot of trouble repeating things. So I'll show you a video right now of someone who has conduction aphasia.
The producer asked us to count to 10. Remember that?
Yes.
Can you do that again?
Why? 1, 2, 3, 4, 5, 7. Boing to Gabriel's people. Go. I can't.
No,
go.
that's really hard. Let me get you started.
I was stunned.
Okay. 1,
1, 2, 4, 5, 6. Better send. Point.
Good enough. Let's.
Is that all right?
That's fine.
What is so interesting about this lady is she clearly is very intelligent, and she clearly understands the instructions, and she clearly can express herself in a very good way. But you could see how after a while she completely disconnects what she wants to do, what she's heard she should do, and what she actually does.
So I think that bloke explained it pretty well, which is why I left that last bit of the video in. But yeah, basically they have that sort of disconnect between what they're trying to say and then actually being able to say it. But as I said, comprehension is intact. So the one other thing I wanted to talk a bit about was apraxia, which isn't really a speech deficit per se, but it's more a motor disorder, and it's a disorder of planning that affects the posterior parietal cortex as well. So in apraxia, so you can have different types of apraxia. So in verbal apraxia, the patient will have difficulty planning and programming what they want to say. They'll have problems in ordering syllables and sounds, and they'll have a very strange rhythm when they speak. Whereas you can also have motor apraxia, which is where you have difficulty planning tasks. So for one notable example is dressing apraxia, where you'll give the patient like a shirt, but they'll have no idea how to put it on. Like they'll know they need to put it on, but they won't actually be able to plan and execute the task. So that's kind of interesting, and it's important, I guess. I just wanted to point it out so that nobody mistakes verbal apraxia for any of the other sort of speech deficits that I talked about previously. Right, so on to the speech examination. This, I think, is really important. It's not something that's formally taught, but I think it's useful to know, because if your patient has had a stroke or whatever, if you're going to go ahead and do a neurological assessment of them, that relies very heavily on them actually understanding and being able to interact with you. And so before that, you really need to sort of assess their speech if you think that their speech could be something that's affected in the context of their injury. So the first part of the speech examination, I'm not going to go through it in much detail. There is a whole chapter in Tally and O'Connor on the speech examination, but I think what's really important is sort of to be able to screen for a speech deficit and sort of come up with a basic sort of way to distinguish between the main categories. So the first thing you want to do is sort of talk to the patient about things that they know and ask them about things that they know. And that's not only to encourage the flow of speech, but also to build a bit of rapport with the patient, because the speech examination can get a little bit lengthy if you do all of the steps in the formal examination. So once you've done that, you need to test comprehension. So the first thing you want to do is test it non-verbally. So you want to ask them to perform some simple tasks, such as like touching your chin, touching your nose, touching your ear. So in Tally and O'Connor, it says that, so the entire command is, can you touch your chin, then your nose, then your ear. This might be difficult for a patient who has difficulty comprehending. So you might want to start off simple and be like, can you touch your chin? And then step it up from there. And then after that, you want to ask some simple yes or no questions. So, do you put on your socks before your shoes? Hopefully no. Yeah, so that's sort of to test comprehension. And then of course you can ask them more complicated questions. But from there, you should be able to sort of start developing a differential without going too much into what exactly they comprehend. So the third step is to test repetition. So you ask them to repeat a phrase. So by doing that, I think I mentioned earlier that in conductive aphasia, the patient has a problem often with repetition, and that's sort of the classical way to distinguish that between other types of aphasia. So you can ask them to repeat a phrase, and that can be any phrase of your choice. It's best not to make these too complicated in the screening, but later on when you actually properly assess repetition, you should always start simple and then step it up. And that's kind of the way it goes all the way through the speech examination. So fourthly, you want to ask them to name things. So 1 or 2 things is fine. Try not to ask them to name super specific medical equipment or something ridiculous like that. Like if you're in a ward and you point at the blood pressure monitor, don't make it too hard. You know what I mean? So other than that, that's fairly straightforward. And then lastly, you want to ask them to say a phrase. So just sort of to see if they can follow that sort of more complex command and then actually articulate that phrase. So the phrase should be of their choice, so it shouldn't be a repetition of something you've said. So don't suggest a phrase in this one. This isn't like step 3. They need to come up with the phrase on their own. So once you've done that screening, you'll sort of understand whether there's a problem or not. And if there's a problem, all you need to do is sort of be like, are they speaking fluently or are they speaking non-fluently? So we saw in the videos earlier that if you are a fluent speaker, the language comes quite quickly and they don't have a stutter and they don't really pause all that often during their speech. Whereas someone with a non-fluent type of speaking pattern, they will stutter and they will pause a lot because they're unable to express themselves. So non-fluent is generally expressive aphasia, whereas fluent is the other types. So then, because there are multiple types of fluent aphasia, the next thing I would say that you should do is determine what type of fluent aphasia they have. So the easiest way to do this is so nominal is naming things, so you ask them to name some things. Conductive is sort of characterized by inability to repeat, so you'd assess repetition. And then receptive is to do with comprehension. So you'd ask you'd ask them to do some things and see if they actually understand. And then after that, of course, you can assess reading and writing, which is strongly associated with speech. to sort of round out your speech examination. But as I said, like, you can read the chapter of the book, and it's not that important to know the entire speech examination now. I just think it's useful because, I mean, I have been asked to do a speech examination, and I just think it's nice to be aware of that in case you do come across a patient that you have to do a neurological test on, but then they don't seem like they know what you're saying. So then a speech examination is good documentation, especially for the next person that comes to see the patient. Because if you haven't documented that they don't understand, or that you did a speech examination, they're lacking comprehension, the next person that comes along will have to do that entire thing again. And that's just pointless. So speech examinations are important, but you don't really need to know them at this stage. What you should take away from this presentation is hopefully you've realized by now that a lot of the neuropath that you learn is really underpinned by the functional anatomy of the nervous system. That's super important, so you should know those areas. And in terms of speech problems, you should know those definitions that I put up. Maybe don't need to know apraxia, but definitely those 4 main types of aphasia, and also the difference between aphasia and then dysphonia and the other one that I've already forgotten. Oops. Anyway, hope this was helpful. Also, please post any questions if you have them, and I will... Hold on, let me just check. Yes, so I have the links to the videos available here on this slide as well, if you want to go back and have a look at them. Anyway, happy studying. I'll see you all next week. Or no, in 2 weeks. Bye. So I've just finished editing this video, and it is a bit of a disaster. But I just forgot one last thing, and that is during a speech examination, your patients can become very frustrated and upset in light of the difficulties that they have speaking. So it's just important to keep in mind that if that does happen, just make sure you're using your empathy skills and really working with the patient to try and complete the examination in a way that's comfortable for them. Yeah, so sorry about the background noise. Hopefully I don't have to do this again, or if I do, that it's better next time.